Where do empathy, compassion, and shame overlap in medicine? That's what we're talking about today. If you're a doctor, healthcare leader, or patient, you belong here. I'm Kim Downey, and this is Stand Up for Doctors Conversations at the Intersection of Connection, Courage, and the Future of Healthcare. By way of a brief introduction, Dr. Laura Jordhen is the founder of Noble Journey Primary Care, family medicine the way it's meant to be, accessible, personalized, and compassionate care. And Dr. Jess Bunin is an ICU physician, retired Army colonel, and co founder and chief architect of All Levels Leadership, focusing on trust and communication in high stakes workplaces. So, thank you so much for the work that each of you are doing. It's critically important, and I appreciate you both.
Oh, thank you, Kim. It's great to
Thanks
be
for
You're
having
here.
us.
You're welcome. And I always ask our guests to introduce themselves as we begin our conversation. And I like to start by saying that I paired you both up because you'll both be attending our physician retreat in the fall. And I wanted all of our guests to get to know each other. So I'm so excited to have you today. And we'll be able to continue these conversations in person. So, Laura, what would
Fantastic.
you like us to know about you?
Yes, so the largest change in my professional life, a very positive one, I am also now coaching medical students at Washington State University. And the coaching program now has us meeting with students across the entire 4 years. So the students who I meet in August all get to work with for their entire medical school career. So this is thrilling. So that and my practice are a good blend.
I love that so much. And today I just shared an episode and we were talking about would you recommend medicine to your children, like if you're a doctor, and how can we
Mhm.
make this more sustainable? And one of our guests, Dr. Scott Miller, his son is in med school. So
Oh,
we need to
fantastic.
make medicine sustainable. And I say so often, since what I've learned all these things, how the culture of medicine has to change and it has to begin in med school. So
Yes.
whatever you're doing is so critically important and it should be expanded and replicated everywhere. So thank you. Thank you.
Thank you.
And Jess, what would you like us to know about you?
Yeah, well, Kim, what you just said, as far as we have to figure out how to make this sustainable, is where my interest comes in. So, my master's thesis was on empathy, specifically in the critical care unit. And what we found was there's a lot of concern about how do I create boundaries? How do I compartmentalize? How do I make the decision about how much of myself I can share before I'm doing harm to myself, before I'm leading to burnout or worse in myself?
Mhm.
And if we're
Mhm.
going to solve this problem of how do we make medicine a more livable profession, a more livable activity on a daily basis, if we're going to think about how to do that, we have to think about how do we teach folks about empathy without
Mhm.
encouraging them to give so much of themselves that it's
Mhm.
harming them.
Mhm.
Hmm.
Absolutely.
Absolutely. And I recently collaborated on a Kevin MD article with Eva Minkoff. She coaches executives, and her husband is a physician. And ours, we discussed, she has this premise about story versus feeling, and how if
Yeah.
you identify with how the patient is feeling, like this must be very hard for you, or I can see you're very angry, like any of those things, without trying to identify as much with their story, because that seems to be the difference. Like we gave the example when we were on the Kevin MD podcast, like if a baby dies, right? And if you're trying to think of, oh my gosh, how would how would I feel that
Mhm.
story if this was my child? Then
Mhm.
that can really, like, again, lead to burnout and all those other things. But if you
Mhm.
think about how they're feeling, which is a feeling of grief, and we've all felt the same feelings, and she felt like
Mhm.
that is a helpful or important distinction. So, Laura, if you have anything to respond to that, and do you have a
Yes.
story that you'd like to share with us today?
Yeah. Yeah. So on the what you just said, perspective taking, that is so important. And Dr. Bunin, we talked about that as well. That the sympathy is how would I feel in your situation, and that's very important, but empathy is how do you feel in your situation? And being open to the fact that other people may respond differently. And I love what you said there about staying in it's really staying in the moment, in present with what's here right now. And that's another way to help um, make it less about, to help make it more manageable, I'd say. Um, I do have a story about a patient encounter that I've shared before that really opened up for me what the power of empathy is. I was um, working at urgent care, and I had a patient who I was seeing who had been taking treatment for alcohol withdrawal at home, and she'd come into urgent care because things weren't going well, and she was there with her husband, and he was sitting back with his arms folded and his cap kind of down, and um, he I was a little nervous looking at him, frankly. I felt judged. But I said to him something about um, you must be really anxious or you look uncomfortable. I can't even remember what I said, but something that just opened the door. And he said, I'm not doing it right.
Mm.
And the air in the room changed, and his fear that he was inadequate was what was driving this, and then that allowed me to speak to it and say, this is bigger than both of you, and you're doing everything possible. And it still gives me chills. They left arm in arm talking about their wedding.
Oh, I that's a beautiful story. It perfectly illustrates what we're talking about today. And like Eva shared in our podcast, is that you can't move forward with a treatment until you identify what's sitting there right then, right? The feelings.
Right
It's like
there.
once you identify or acknowledge how a person is feeling and they feel
Yeah.
seen and heard, then you can go on to talk about the treatment. So that is so beautifully illustrates that.
Yeah.
Thank you. And Jess, what does
Mhm.
any of this bring up for you? And then if you'd like to share a story.
Yeah, well, first I want to comment on Laura's situation because our research pointed directly to this, which is
Yeah.
that if physicians are going to be able to develop more healthy empathy for their patients, the two things that patients can do that are really helpful, number one, it's to have that emotional expression, to be willing to
Right.
show that and willing to talk about it, even if it's hard, even if it's
Mhm.
scary. All of that was very important. But then also, to be really free in asking for help. The help seeking
Yeah.
behaviors shift from what we think of as empathy to more of what I think about as compassion. And so Laura
Yes.
talked about the difference between sympathy and empathy being instead of, how would I feel? How would you feel? I think if we take a step further to compassion and say, and
Mhm.
how can I act on it
Yes.
to prevent empathic distress in myself? And a way we
Mhm.
can act on it is our patients asking us for what they need. And so I
Mhm.
think that that's a beautiful connection for Laura does family medicine and I do critical care, and they're very different
Uh-huh.
specialties in how we
Mhm.
think about it on a daily basis and how we practice
Mhm.
it.
Mhm.
And I'm a really firm believer that empathy is a bell curve.
Mhm.
If we don't
Mhm.
have enough empathy, we suffer because we don't feel fulfilled as providers. Our patients suffer because they don't feel heard as patients. And if it's too much, then we have this over arousal. We can't think straight. Our brains are stressed. We
Mhm.
don't do the right things for our
Mhm.
patients.
Mhm.
And then we suffer because then we develop burnout, or we
Mhm.
avoid being with patients, or we
Mhm.
avoid the patients that arouse too much empathy in us. But if we can find that middle ground
Mhm.
between those two extremes,
Mhm.
that's really where we win. But
Right.
a lot of times, where we find that we fall into one of the tails of that bell curve is
Mhm.
when we identify too strongly with the
Mhm.
individual in front of us. And so, a story for me is as an intensivist out at Tripler Army Medical Center, we had a 33-year-old man who died in our intensive care unit. And it was the most traumatic experience
Mhm.
for folks in that age range in our unit because not only is it a young person dying, which is horrid, but they identified themselves in that person. It was a military person who came into the hospital, who had a complication and died. And so there was so much guilt and so much this could have been me, and all of those sorts of things. And his wife had just had a child, and so folks who had babies at home or children at home really struggled. So that familiarity bias, that over identification, can really make it hard.
Mhm.
Mm.
Yeah, I'm glad you brought up compassion and the neuroanatomy. The research into neuroanatomy is phenomenal in that 6 hours of compassion training can change the brain, and compassion training reduces empathetic distress. Compassion is that desire to act upon what we're learning, and I think physicians often confuse acting with I'm going to cure this, I'm going to solve it. Acting maybe I'm present here for you, whatever happens.
Yeah. And ironically, the action that allowed our unit to start healing, well, first of all, there we did a lot of peer support work, which I think was huge. But also, a good number of us went to the funeral. And we
Mm,
felt like that was action. We were actively supporting the family and doing everything we could to experience our emotions and show them that we cared. And so that was a form of action for us also.
exactly. Exactly.
I love all of that. And when you were speaking to what patients could do, right? When you alluded to like willing to be vulnerable and willing to ask for help. And so interestingly, like doctors and patients, you could say are two sides of the same coin. And doctors too, right, need to
Mhm.
be willing to be vulnerable and ask for help.
Mhm. Yep. This is fascinating. I came across this paper actually yesterday by an author, last name Chen at Boston University. And this paper studied medical students and empathy, and it compared self rating of empathy in the second year and third year versus observed empathy. In the second year, their self rated empathy was higher and then declined into the third year, but their observed empathy increased, which is fascinating because it also mentioned in the paper how terrible physicians are at rating themselves.
Well, Laura, I found that study fascinating also. I really ruminated about that study for a long time to
Uh-huh.
try to understand it better. And it was so interesting to me. And what I walked away with from my context is in the
Mhm.
second year, we're learning it. We are
Yes.
developing these skills and these scripts and
Yep.
forced to make eye contact and all of this. And then when we get into the clinical space, we
Mhm.
start developing this habituation. We
Mhm.
start having some under arousal because all of our
Mhm.
patients start looking the same to us and we do more
Mhm.
depersonalization. And so
Mhm.
even though we are still doing the things we were taught, we're still
Mhm.
making the eye contact, we're still
Mhm.
asking all the right questions, we feel it less,
Mhm.
which is
Mhm.
just an interesting aspect of that as
It
well.
is. It is. But the patient may still get the full benefit
Yes.
from just the skills we have. And so some of the task here is just to recognize what we are doing, to allow that connection with the patient to
Mhm.
be sustaining, to be what provides you the energy for that
Yeah.
day, and
Yeah.
to recognize it.
Yeah, 1000% agree, right? Like, how do we find that place where our patient experiences everything they need to experience to have
Mhm.
all of the benefits of empathy, to have the
Yeah.
better outcomes, to have the better communication, and
Mhm.
have a place where we are keeping our providers safe
Yes.
from burnout?
Yeah. And self-awareness is so critical. Empathy starts with self-awareness, but that ability then to separate self and other, it's also critical there in that metacognition, meta emotion.
Yeah.
And I don't know that we're teaching self-awareness explicitly. And there's certainly a lot of implicit messages that go against that.
And I have to say, as a physical therapist, a lot of this obviously pertains and relates because I've worked in settings from the NICU, right,
Mm-hmm.
to nursing homes with and so all of this applies there, and that there is that I know, like you described, the empathy bell curve and over and under identifying, right? And you do want to find that sweet spot because it doesn't help you or the patients if you become numb to it all, right? Then you lose
Mm-hmm.
your passion for practice. So, but as you're saying, you're not trained these things in med school, or even I went to PT school in the 80s and we weren't, I don't recall being taught these things either.
Mm-hmm.
Yeah, I'm going to
Yeah.
throw in a shameless plug since you use the term self-awareness.
Oh.
But I
Yeah.
have a book coming out this fall, published by the American Association of Physician Leadership called Self-Awareness and Trust.
Oh,
And
fantastic.
that's what it's about. Like, how do we teach
Mm-hmm.
providers
Mm-hmm.
and physicians to
Mm-hmm.
lead teams effectively with that
Mm-hmm.
self-awareness, but also to care for patients with that
Yeah.
self-awareness?
I teach dental residents. That's my side gig. I do it just for fun at Oregon Health and Science University. And we meet once a month over 9 months. And one of the ways I approach the self awareness is through the body. I have them doing role plays and then paying attention to what are my shoulders doing? What are my hands doing? What do I feel in my chest as a safe entry place and a safe place to talk about in the room.
Yeah. And everyone feels that differently, right? Some people feel
Mhm.
stress in their chest, some people feel it in their stomach, some people feel it in
Mhm.
their jaw. So helping
Mhm.
individuals identify how do they
Yeah.
experience these
Yeah.
feelings.
I shared with them a study that looked at the bodily topography of emotion, and people from both um, Europe and Asia drew out on these bodies what emotions feel like, and the coherence was incredible. So it would be like a weather map in a way, from hot to cold, and you look at it and you're like, oh yeah, that's shame. You know, the little cheeks are red,
Mhm.
and so it's something we all share. Another study I looked at the components that travel with burnout and with flourishing, and alexithymia, the inability to read your own emotions, traveled with burnout. So that just tuning into the body, and that's as simple as one or two breaths. It's not going on a retreat, which I love it. The retreat
Yeah.
is great, but it's
Yeah.
right here. It's as close as your breath.
Well, and I suspect that some of this is unfortunately baked into medical training, in that you're taught or trained or you must suppress your own needs while you're taking care of patients.
Mhm.
Literally, not being able to eat when you're hungry, or drink when you're thirsty, or go to the bathroom when you feel like you need to go to the bathroom, or sleep. And then you end up not being able to tune into your own needs, whether they're physical or emotional. And you also mentioned shame, Laura, and I also did want us to touch today on how medical training cultivates shame while trying to cultivate excellence. If you both like to speak to that.
Yeah, Jess, I
Yeah.
loved your
I mean,
paper.
I love this topic because it's so important to me. And we attract folks who are perfectionists. By
Yeah.
being in medicine, they have attention to detail, they want to succeed, they want to be the best in their field, they want to work hard and do all the right things. And then we put them in medical school. And 4 years later, their sense of perfectionism is even stronger. And we make a little bit of a shift from what might have previously been a little bit of an adaptive professionalism, meaning they wanted to be better, they had strong goals for themselves, to this maladaptive, which is now I have to figure out how I'm going to please all the people around me, while most of the time I feel like I'm faking it and not doing a very good job. Right.
Mhm.
So that's that maladaptive perfectionism. And once we start practicing maladaptive perfectionism, we shift from guilt to shame.
Mhm.
And it's so dangerous for us because if we have guilt, guilt is great, right? Guilt says, oh, I did something wrong. How do I do it better next time? How do I get help? How do we work as a team to make this better? But shame says, I'm bad. I'm a bad doctor, I'm a bad person, and I can't fix it, and I can't talk about it because
Mhm.
people definitely can't know. And so
Right.
that shame just builds and builds and builds because we don't talk about it.
Mhm.
So
Mhm.
I think a solution to that is taking our coaching that Laura is doing and
Yes.
taking the mentorship that we're doing and turn that into shame-informed mentorship.
Yes. Yes. It's
So we're
so
think, go ahead, Laura.
yeah, it's so powerful to be able to share with a student um where some have shared with me some stories of not doing well, and I can say, hey, a lot of students make that a story about their worth, about who they are. Has that happened to you? Another way to think about it is, you know, that this is a thought I'm having, but it's not who I am. That distance, that 1 degree of distance of, oh, there's that interesting thought about how I'm not worthy. Ah, look at that. And
Yeah.
let it
And when
go.
they can't do it themselves, having us just say and remind them, this
Yes,
doesn't define you.
exactly.
It doesn't define
Exactly.
you. This is one thing that happened on one day of your life. It is not who
Exactly.
you are.
Right. Right.
Absolutely. So we've had conversations in the past. I have talked about shame and shame in medicine. And but I haven't actually, I don't think, heard the term. So I've interviewed doctors who have gone on to learn about like trauma informed coaching,
Mhm.
right? So but I don't think I've actually recall hearing like shame informed coaching or shame informed mentorship. So that's a little bit of an aha for me today. So I'd like you guys to speak, women, to speak a bit more about that shame informed coaching and mentorship.
Yeah, well, I'm from New Jersey and we call everybody guys, so I'm not going to get offended by that.
Yeah.
So don't worry about that.
Okay.
I'm also okay if you call me a chick. So either way, I'm going to be okay.
Okay.
But shame-informed mentorship is not a topic that's out there. This is something newly coined by my peer, Dr. Gail Heischer-Rollo, and myself, in an article where we really thought about a lot of Will Bynum's work in shame and thought about how can we connect this through and make the difference. And we see three big areas where mentors can learn to think about this and help. One of those is just recognizing shame. What does it look like? What does it feel like? What do people say? What do people do? And interestingly, this is really different by genders. So
Mhm.
men tend to get angry and distant,
Mhm.
and
Mhm.
women tend to say, I should have done better. Should.
Mhm.
And they do get the red cheeks and they get the embarrassed feelings. And so,
Mhm.
again, this is very generalized. There's a spectrum of gender, we know, but sort of on the polar opposites of that, that's how we might think of it. So, being on the lookout for those things. So,
Mhm.
the recognition
Mhm.
is number one.
Mhm.
Number two is figuring out how to navigate shame events. How do we help our
Mhm.
learners do it? And part of it is exactly what Laura just said, which is like, this doesn't define you. This is one thing that happened. How do we get you to
Mhm.
step back and realize it's just a thing that happened? But
Mhm.
also, we can do things as the mentor. We can say, I don't know. That happened to me too when I was a resident, and
Mhm.
I'm doing
Mhm.
okay. And I actually recommend people maintain a CV of failures so that when folks come to you and say, like, I did this thing and I'm never going to recover, you can be like, oh, yeah, look here, it's on my CV of failures too. I
Mhm.
did that too. Or
Mhm.
here's something that's like that I
Mhm.
did.
Mhm.
So
Yeah.
recognizing it, navigating it. And then that final thing is how do we cultivate that shame resilience?
Mhm.
And I think that's a lot about doing the mindfulness work that Laura's talking about, doing a lot of the peer support work and peer mentoring work,
Mhm.
where people can talk about these things in psychologically
Mhm.
safe environments.
And the incredible thing is when I have made mistakes with patients and have been immediately upfront, transparent, the the forgiveness, the understanding has been incredible. Missing a fracture, and with my full presence, it we navigated it, and the grace that I've been given, as opposed to trying to cover it up, trying to avoid, and that's what where patients get really frustrated, and lawsuits are about not getting answers and not getting an apology. not about the degree of harm necessarily.
That's absolutely true. And one of these days, I do want to have a podcast specifically on complications. And I recently communicated with a physician who caused he shares this in a post, caused an injury which I deal with on the other side, like as a patient, and
Mhm.
really in not sharing it, but really this is how we heal. Like doctors and patients can heal together if they feel safe, like to have these kind of
Yes.
conversations in a safe way. So
Mhm.
I'm looking forward to speaking to that a bit more in the future. But I love everything you've both just shared, and also that CV of failures, of course, not to dwell. It's not like you're keeping a log all the time of like everything you
Mhm.
do wrong, but also to see how you move forward and that it
Yes.
didn't define you. And
Mhm.
then sharing our stories is everything. And that's why I do this podcast, because I say so many times every time a doctor shares their story, another doctor feels less alone. So if you are able to be willing and vulnerable to share these things, it can support your peers and sometimes can even save a life.
Yeah.
Mhm.
Yeah. Brene Brown always says that shame can't survive the light, right? As
Yeah.
soon as we start talking about it, the shame starts
Mhm.
dissipating.
You think
Mhm.
about that story I shared earlier about that patient, a guy who his thought was, I'm inadequate. And the expression was anger. And yes, we see that all the time.
Mhm. Wow. Laura, is there anything you'd like to add to our conversation about teaching compassion and human connection, or anything you want to make sure that you share today?
Yes, so David Foster Wallace gave a speech, and now it's a book, This is Water. And it's a story about the fish not knowing what water is. Having the curiosity to look at, okay, this is the water we're swimming in. I get that now. This is the soup we're cooked in, and to examine that. So just curiosity, openness to discovery about yourself, even though that's uncomfortable at times, can be life changing.
I love that so much. And my physician coach is Dr. Michael Hirsch. And I had found his blog a few years ago, and I was reading every one. And he did one on This is Water. And I actually
Good.
shared it as a devotion for my women's fellowship group. So I followed his blog
Mm,
for 9 months before I reached out to him. And that's when he was celebrating his year of blogging. And my doctor had just died, and I didn't know how to move forward. So some of these articles and books and topics, like they really do make a difference. So thank you for spotlighting that. And Jess, if there's anything you would like to add about your empathy research or leadership or shame informed mentorship or just anything else you absolutely want to share today.
Yeah, I mean, all the things. I want to talk about all of them for another 3 hours with you too.
yes.
But I think really key factors for our trainees is two things to be defining the terms. So again, the sympathy, the empathy, the compassion, how do we
Mhm.
use those effectively? What does it mean? How does it affect our patients? But then having that very transparent conversation about
Mhm.
the risks and benefits of all of them
Mhm.
and teaching them that you don't need to give all of yourself when it's dangerous to do so. You
Mhm.
can have your barriers, and that's okay. It doesn't make you a bad doctor. It doesn't make you a bad person. It makes you someone who wants to do this job long term. And so, having those very
Yes.
transparent conversations, I think, is very important.
Yes. Yeah. Compassion. It's not that too much compassion burns you out. It's a lack of boundaries, and that's an important distinction.
It is. It is. So do you each have like a take home action message for our audience that you'd like to share today?
Mm. Yeah. Be curious. Think about what's the water.
Yeah, I love that. And I'm going to go back and say the same thing, which is be okay with saying, I don't know. I'm not
Yeah.
sure. Let's
Yeah.
figure it out together. Like the you as an attending, you as a senior physician, you as an educator, being willing
Mhm.
to show the vulnerability of you not knowing might
Yes.
save that one person from that shame experience.
Yes. Yeah. If there's only one thing that you do in a difficult time, maybe it is just thinking other people feel this.
Yeah. And then one other thing I think is important for us all to figure out how to keep in our minds is when someone has a clinical struggle, when they feel like they can't muster the empathy or they're experiencing shame, we need to figure out how to remind ourselves that that's a systems issue.
Yes.
Burnout is a systems issue. This
Yes.
isn't a failure of the individual, it's not a failure of their character. There's a problem in the system that we can fix together.
Yes. Yes.
There absolutely is. And at our physician retreat, we're going to have time to talk about all of these things. Doctors that are coming for support, doctors who are looking to innovate, doctors who want to talk about system change. We're going to have plenty of time for all of these conversations. And I love when you said that other people feel this, because other things I say all the time is it's not just you. You're never alone, and there's always a path forward.
Great.
So, yeah,
Okay.
well, thank you both again for being my guests, and I can't wait to continue this conversation in person.
Yes,
Thank you so much for
likewise.
having us
You're
All right.
welcome.
and for
Thanks,
bringing Laura
Kim.
and I together, which
Yes,
is going
it's
to
been
have
phenomenal.
wonderful effects going on and
Yes,
on and on. I can't
absolutely.
wait.
Yeah, this is so
Absolutely.
exciting because I've recorded before yours two other episodes where I've been pairing our guests up for the retreat. So everyone's gonna come like knowing a friend, and and so it'll be the retreat won't be the beginning or the end, it'll be the middle.
I love it.
Fantastic. Thank you,
So,
Kim.
yeah. Well, thank you all for being part of our Stand Up for Doctors Global Neighborhood, a place where physicians and those who care about them can connect, empower, recharge, and celebrate. You'll find more stories like this in our White Coats book series. And if you're a doctor, we'd love to welcome you to our inaugural physician retreat this October, where these conversations, as we said, will continue in person. And we'd be honored to have you join us. And if you'd like to help sustain this podcast, please consider sponsoring an episode or connecting us with a mission aligned sponsor. And links are in the show notes, including how to reach out to our guests. And in closing, to move the needle in healthcare, we all need to raise our voices and we all need to care about each other. We already know that doctors need to care about patients. Patients need to care about doctors too. So stand up, doctors, and let's stand up for doctors.